Marlene Dines. I'm the National IDM Leader at Kaiser Permanente, and I am part of a team called Employee Safety, Health, and Wellness. I'm part of that leadership team, and we roll up to National HR. It's been a great 2 days. I don't know about you, but I've heard a lot and I've learned a lot. And you might have noticed maybe that we're hearing variations on this very important theme that we all came here to learn about and think about and talk about. And you're going to hear it again, another variation on that same theme. And probably you're hearing it now for about the, I don't know, maybe 12th time. But we have a senior leader in our organization in Northern California named Dr. Robbie Pearl. And he has a saying that, where he says that you need to really hear, a person really needs to hear something about 17 times until it finally sinks in. So you'll hear it again for now, about the 12th time. And Robbie, this one's for you. So I'd like to now introduce my colleague, Dr. Nicole Stelter, who will begin the presentation for us.
Thanks, Marlene. Hi, everybody. I'm Nicole Stelter. I'm a portfolio lead with Kaiser Permanente in the HealthWorks division. I act as both an internal and external consultant with our customers, but also work with Marlene and her colleagues in National Human Resources in occupational health, disability management, EAP, wellness integration. So I'm very happy to be here. Thanks very much for having us. I'm going to go ahead and get started. I'll tell you that I had a joke, and it was going to be hopefully funny. But then I saw, which, you know, the worst thing 5 minutes before you're going to present is finding a typo in kind of a major part of your presentation. So we've decided to turn it into a quiz for any Kaiser people in the audience to see if you can find it in the next. Let's see. I think it's the next slide. It'll be after the agenda slide. So Kaiser people, watch out for the big typo. So I'm going to set us up, set the table a bit with context, a little bit about Kaiser and the structure, a little bit about what we try to do in working toward a total workforce health vision. And then Marlene is going to take it over and talk to you in depth about the Integrated Disability Management Program. And then we'll try to pull it together around objectives and metrics, and hopefully end with enough time to have some good questions and discussion. All right, Kaiser people, show of hands. All right, so this is a bit about Kaiser. One of the things that's really important, I think, aside from the structure and kind of the brass tacks of it, I haven't seen any Kaiser hands go up. There's nobody's seeing the typo. Oh, Jennifer, you're cheating. I told you what it was. So, but an important thing to think about when you're doing integration, the way that we are defining integration with the Kaiser programs, is integration on a clinical level as well as an administrative level. So it's already difficult to do that when you factor in the number of programs, IT systems, all of those things. The other thing that is difficult is the structure, but also a very matrix and consensus culture. And that makes for a lot more challenge around getting to common definitions and metrics and strategies. And so, which is a whole nother presentation, but to keep that in the back of your minds when you're hearing about Marlene talk about the journey that she's been on to bring the IDM to fruition. Did anybody find the typo, Kaiser people? There are 7 Permanente medical groups, not 6. Okay, there you go. See, I could have just kept going. They would have noticed it. Okay. Okay, this is the bulk, really quickly, the bulk of this is our workforce and how it's made up. This also includes approximately 18,000 physicians. But here again, you can look at the permutations, right? 30 separate bargaining units. We're really talking about, again, how many different people at the table and having input and to get aligned. So talking a little bit about total workforce health, the way that we try to look at it, and this is one of, I'm sure, many concepts that any of you have ever seen, but this poor guy in the middle is really your HR VP trying to manage outcomes and cost and impact metrics. And oftentimes what are siloed programs, if you're lucky, you have some of these in-house, so you have a little bit more control over management and quality. Sometimes, depending on who you ask, if you're unlucky, you've got all of these outsourced. and you're trying to manage different vendors, different contracts. You've got a different set of accountability maybe with each, and in some cases, you have different reporting structure where Occ Health might be going up through the CFO, everything else might be going up through HR, so it can get a little tricky. I think from the business perspective, that's one thing to think of, but the other is from the employee perspective and how difficult it is when you have an injury or absence or a family member who has something where you need to be away from work or need to have some accommodation. And you have access to these great programs. You may know a little bit about them. You may know enough just to be able to make one phone call and get horribly confused and not know what to do from there. So getting engagement with a program set up like this is difficult, and aside from the customer satisfaction or employee satisfaction part of that, it's hard to get people engaged, and it's hard to get them really taking advantage of the programs that are available to them. Oh, sorry. All right, so this is a little bit about then what we try to take in that as-is model to move towards. Just narrowing it down to these are obviously not all-inclusive, but these are the 4 big programs that we try to pull together as it relates to strategy and what we measure in terms of outcomes, workforce wellness, leave management, Occ Health, and then EAP. So the idea being that when we also add in the integrated care delivery system that Kaiser employees, for the most part, do access as employees of Kaiser, they access the Kaiser integrated care delivery system. There's a way to really measure that, measure them against each other and with each other and not have them siloed, so that you're not measuring the outcomes of your health plan, you're not measuring just the outcomes of your wellness program. You're able to pull the different metrics together and the programming together. And again, I'm not talking just necessarily about process improvement or administrative redundancies. I'm talking also about clinical, which is really where you can get a lot of great compounded positive outcome. And again, data reporting is really the piece that ends up pulling them together. In some ways, it's kind of like having 5 different languages, and you do need a way to have translation and connection between those languages. That's really what your data and reporting is about, and where you can align any of the metrics within the programs to each other, and not just within the programs. You're going to get further. So Marlene, I think this is you. You ready?
Yes.
You're in the Jimmy Fallon show.
Okay, thank you. So I don't think I'm telling you anything you don't know when I ask the question, what is integrated disability management? But right now I'm speaking generically. I'm not talking about our program yet. But we know that it's people in various functional areas, and we're talking about HR, disability case management, occupational health, employee health, EAP, certainly our vendors. These are the people in the various functional areas that all work together to assist our employees with illnesses and disabilities. In the past, we thought it was revolutionary when we integrated disability services for occupationally injured employees and employees with personal health conditions, and that was called integrated disability management. But what we've learned is that we really need to go beyond the Occ Health and non-Occ Health model, because disability management really needs to be a continuum from prevention all the way through to the concept of stay at work and return to work. That doesn't, oh, I'm hitting the wrong one, I'm sorry. Okay, because ultimately we want to ensure an environment that truly promotes employee safety, health, and wellness. And we do this, first of all, by integrating with workplace safety and workforce wellness. We certainly want to optimize employee functionality while they are healing, and we do this with the help of our clinicians who are guiding them through the healing process and guiding them through to their ultimate return to work. And if we have a collaborative effort, then surely our employees will be much more productive and will enjoy the job security that they come to work for every day. A strong IDM program will reduce the duration of disability-related absence using interventions with key functional partners. It will support the managers to understand this stay-at-work, return-to-work culture that we're trying to promote, and we will ensure that through education and reinforcement of this important message. We'll increase workforce effectiveness by basically preserving our employees with these challenging, disabling conditions, and improve health outcomes for employees engaged in work during recovery, and again, with the support of our workforce wellness and our clinician program. If you have an effective IDM program, you will have immediate and collaborative intervention by the partnership, by partnering all your functional areas and not just the usual HR with managers and employees. You'll have appropriate return to work placements, appropriate and optimum, and this means when they should happen and how exactly they should happen. When you apply job modifications that you've offered to employees in order to bring them back to work safely, you basically identify a safer working environment that then becomes the new way of redesigning your environment so that you can ultimately reduce any potential injuries from happening. And then, of course, pretty self-explanatory, but the best outcome of an effective IDM program is your employee retention and sustained productivity. So now I'll talk to you a little bit about Kaiser Permanente. Kaiser enjoys, and I say enjoys, a unique labor management partnership, which began in 1997. And the LMP model is applied across many different areas. But in 2000, the LMP basically mandated that Kaiser Permanente would have an integrated disability management program. In 2005, they put that mandate in the language of their national agreement, and with the goal to remove barriers so that employees that are capable of returning to work can return to work, and whereby managers agreed to facilitate return to work by liberalizing some of the work environment and work requirement issues, and the unions agreed to work collaboratively with managers and with the IDM program to identify return to work opportunities for employees. And really goes without saying that the positive for all of this was going to be a win-win for everybody, and it has been. But eventually, from about 2005 to 2011, we established these IDM programs in all of our regions, and with a management co-lead and a labor co-lead, and people in their IDM committees meeting charters and plans and delivery of services for employees. But eventually, what we were seeing is in our different regions, we saw that there was a lot of autonomy. You know, they designed their programs to fit their culture, maybe their environment, maybe their geography. But because they were so autonomous, there were many independent efforts, and with wins, with legitimate wins, but really little or no collaboration. There just wasn't enough sharing. The other challenge that we were faced with is it really wasn't a formal way of measuring the impacts and the outcomes. And everybody knows, and this is one of the things you've heard a lot today, is that if you're not able to measure the impact and the outcomes of the work that you're doing, eventually you're going to lose leadership support, and that was starting to happen as well. And then finally, we saw that various internal functions, as well as the work of our external vendors, it was going along fine, but it was all going along in silos, and what resulted was a lot of duplication of effort, and in many ways, competition for attention and resources. So, in 2011, our chief HR officer said, we need to make a change, and we need to look at a better way to embrace the value that IDM could bring to our organization. So he formed a task force of senior leaders from different functional areas and across our regions, and supporting that task force were a community of IDM subject matter experts, so that these were not only the doers, not just the case managers, but these were also subject matter experts in workplace safety, in EAP, in employee health and OC health. These were the people that really understood the needs and the value of IDM because they pretty much worked it every day. And the purpose there was to fully realize that one point of coordination for the integrated disability management could lead to many wins for our organization. Certainly accelerate the spread of successful practices, and that meant that sharing these great practices that were coming out of the regions, that were being developed in the regions, and also surfacing issues for discussions. And that meant not only issues that we were learning about from within our organization, but issues that were happening outside of our world, and issues that surfaced at meetings like this, as a matter of fact. And in terms of coordinating programs in different parts of the organization, you're going to hear a little bit more about this as I move on to some future slides. So, but the purpose was obviously focusing on prevention and management of work absence and lost time, and doing this by creating a culture, both a culture and an operational environment that fully supported health and productivity. And this dual focus on both culture and operation was very important, and that was going to be a priority in how we approached our reinvented IDM program. When we say program level coordination in our organization, program level means that there would be national coordination for IDM matters and issues that had interregional impacts and that could benefit us in an interregional, cross-regional way. And that we knew that if we all worked together on this, that we would eventually create and reinforce a culture of safety and functional ability, and truly the management commitment to support our employees so that they could return to work even during the healing process. We had advisors in our organizational effectiveness department, so a slide like this might look familiar to some of you. When you look at things through the OE lens, you see that there's a goal, and you identify your drivers and your objectives. And in this particular case, when we were creating the holistic system view, that meant everybody involved in the task force and the SME community were really contributing. What did they see in our world of IDM? What did it include? What did it need to solve for? And basically, what were the parameters, but making that box as big as we could. And then we were going to establish priorities to focus on, because we knew we couldn't do everything. We weren't going to boil the ocean. So we had to look at everything that had to get done, but then really prioritize what we knew we could get done in a reasonable amount of time. And when we launched our SME community, our subject matter expert community, that meant that we actually convened everybody so that they could get to know each other face to face, brought in the regions from all over the country so that they could actually sit down, identify the priorities, roll up their sleeves, and start planning what is the work that had to get done. And this was all done in a very, very, very collaborative way. It was actually a very exciting part of the process. And then we began our focused action planning and using assessment data to identify what improvements could be made to the IDM program, and then recommended the improvements to the task force, got their endorsement, and then ultimately launched the improvement work. But of course, before you do the improvement work, it's almost naive if you don't immediately identify, well, what exactly will be the risks, and what are the issues around the risks, and what might we approach as the mitigation for those issues or for those risks. So the first risk was leadership's commitment, and that meant not only leadership within HR, but leadership outside of the HR community. And I just heard in the presentation that Dr. Leopold did, he talked about getting through to the people in operations, and we knew that. And we knew that in order for operational leaders in our medical centers and our service areas to allow people transitional work, allow people to ease back into the work environment, we needed their commitment and their support. But we also knew that we weren't going to get that without giving them data, which meant we had to demonstrate how serious was the problem and what were we going to do to produce some positive outcomes. The next risk was validation of the work. So we have our disability case management teams in all of our regions doing some really great work, but how were we going to track it? How were we going to tell our story and demonstrate that this is everything we're doing and this is how it's making a difference? So one of our regions, one of our larger regions, developed an electronic database which was working well with them and was even integrating with our HRIS system, but unfortunately only one region had it, so we knew that we had to identify a solution like this for all of our regions. We now have a second database that has been established, and again, it's so much of it is about tracking your processes and your milestones so that it can help you ultimately tell your story. The third risk was data integrity, and I know this is something that challenges all of us. And I know it always frustrates me when whether I'm going to a presentation or reading articles about how to speak to the measures for your IDM program or your absence management program, and they all say, well, you know, turn to your STD carrier. Well, yeah, we have a great STD carrier, but 80% of our employees are in California, and we rely on the state disability insurance. So we just don't get the information from them that we do get from our STD carrier. So what we did was we aligned with our HR operations and decided that, well, we know that we're tracking leave data. We know we're tracking all of our employees on leaves, OCC and non-OCC and FMLA, and we felt that, well, if this is our system of record, that should be reliable, so we were going to utilize that data. And then, of course, still challenged with you know, well, how accurate is the data, and you know, really diving deep into how it's being inputted in all of our various regions by whether it was various HR departments or whether it's managers. So, but the mitigation really was aligning with HR operations and HR technology so that we could have confidence in the data that we were using. Oops, I didn't mean that. But then the fourth risk was speed of outcomes. Could we demonstrate outcomes fast enough to hold on to the leadership support that we were so dependent on? We got their attention, you know, we got them all to be part of the task force, but now we needed to sustain it. Now we needed not only to sustain the leadership that we had, but we needed them to influence those operational leaders that needed to allow us the time and the bandwidth to be able to do the work that IDM needs to do to make a difference. And of course, you know, you all know this, it's reporting and scheduling reporting and making sure that you're demonstrating the progress. So, in terms of measures of impact and value, and this is a very simplified version of a very complicated dashboard, but very simply what we decided to start with, and this is not the end of how we're going to measure our input, but this is how we decided to start. And first of all, just to show exactly what is the state of our situation, or how bad are things, that the total number of employees on an impactable leave as a percentage of our total number of employees. And what we did was we identified, or we defined, that we would do an IDM impactable leave. So this is not the whole discussion about absence, and this isn't the whole discussion about presenteeism, because remember, we're trying to establish support for our IDM program. So we call these IDM impactable leaves, and these were the leaves that were for employees only. These were their occupational leaves and their medical leaves, but only for their own personal health conditions. And we filtered out FMLA for family and FMLA military, just so that we can show that this is the work that our IDM professionals are doing, and this is the benefit that they're bringing to the organization. And then we identified transitional work, because it's pretty much It's the number one strategy that at this point we've been up until now, we've been most successful with. And we have been measuring that, so that was a number that at least we knew we could rely on. We wanted to look at the total number of employees on transitional work as a percentage of the number of employees that are on an impactable leave. And then we measured the recovered lost work days, because once those employees are on a transitional work assignment, which means it's modified work until they're back to their full work, they're back on pay. They're back on pay and they're back on benefits. Their lives are whole. And we put them to work in very legitimate situations. Sometimes it's their own job with a modification. Sometimes it's a different job within their department, and sometimes it's a different job in a different department. But all of these jobs are meaningful and valuable, and as I referred to earlier, they are part of the healing process. And I'm going to do this one very quickly because I realize there's a lot more to talk about here. But basically, we're separating out the burden, and the burden is the cost of the lost work days. Now, up until now, when I have discussions internally at Kaiser Permanente, I talk only, right for now, only about the lost wages, because we know lost wages is a very simple way of looking at lost productivity. Because our number, that's scary enough. That's $370 million a year. And that was scary enough. If I were to add wages and benefits, well, then it jumps to $502 million a year. But at the right time, I'm going to hit them with the full formula for lost productivity, which is IBI's formula, which includes that magic multiplier, and it's actually $703 million a year in lost productivity because of disability-related absence. So how can we demonstrate that the IDM programs have made a difference? We're capturing those recovered transitional work days. And for last year, it was 141,312. And this might actually be an underestimation because we think there's a lot more of this going on that we actually haven't been able to keep track of. But if we're looking at the value of those recovered work days, we have 43 million just based on the wages, 58 million, actually 58.6 million wages and benefits, and then the formula, the real formula for lost productivity, $82 million, that we've been able to recover as a result of these transitional work activities. But now I'm going to talk about what I call putting the I in IDM, because our solution, and you heard me talk about the continuum from prevention all the way to return to work and stay at work. Integrated disability management is more than just integrating services for occupational injuries and non-occupational injuries. It really relies on integration with those key functional areas, starting with EAP, which is there to support our employees with emotional needs, financial needs. It's also there for managers who are having difficulty adjusting to employees that are either returning to work or leaving work. EAP is there to support everyone. And then, of course, workforce wellness, and we call our program Healthy Workforce. And these are the programs that the resources, and you'll hear more about them, that support employees to stay healthy, to maintain a healthy lifestyle. Because when you're out on a disability, you might be out on a disability because you're having hip replacement, but it's still important that you watch your cholesterol and then you lower your salt and that you maintain a healthy weight. And these are the resources that are available to keep our employees healthy while they're out on disability, and then also to keep them from going out on disability. And then, of course, occupational health, employee health, and the great clinicians in our organization, they're very much a part of our integrated process because they are truly partners in the whole return to work and healing process. And you know, as I alluded to before, working with our vendors, our workers' comp and our short and long-term disability vendors is very much a part of the integrated process. workplace safety, we're talking about prevention, we're talking about bringing our employees back to a safer environment, and certainly we look to workplace safety for those ergonomic solutions, for those optimum job modifications, and we learn from them, and they then learn back from us. And the HR and the LOA administration, again, we rely on them for the data. We rely on them for the process. When an employee first goes out on leave, that's the first communication they get after reporting their absence to their manager is they hear from the HR Service Center as far as their leave of absence administration, and that's the first opportunity to guide them through the very critical services that will help eventually bring them back to work. But now we're also integrating with attendance management. Attendance management has the same goal that disability management has. We want everybody to come to work every day, and we want them to feel better too. And there are many mutual strategies that we could be sharing with each other, starting with data, starting with how we identify those metrics that will truly tell us what the picture, the story is of absence and attendance and disability in our organization is. And then we have a functional area at Kaiser Permanente called workforce planning, and this is the department that identifies high needs positions in our organization. We may have somebody on a disability leave, say, from nursing, but we've got a need for people with that medical background in our advice and our appointment advice center, something like that. Anyway, the place that you call when you've got a medical problem, you want to talk to a nurse. And this is a great place for our nurses to transition into when they can no longer do the heavy physical work that nursing requires. Well, workforce planning not only works with us in terms of identifying high needs positions, but for our labor represented employees, we have grants, training programs that they're eligible for, as well as career counselors that can help guide them into positions that they can do so that they can remain with Kaiser Permanente, and so that we don't lose this valuable pool of resources of employees that we've invested in that we really are committed to and really want to keep. And then, of course, why not recruitment, right? I mean, you know, we want our people to be able to go back to work. Sometimes they just can't return to work to their regular job. Recruitment services is there to help us and help those employees identify jobs that they do qualify for. And you know, we don't give preferential treatment, but maybe a little hand-holding just to help get them through that process. Well, that's the who of that's what I call my circle of circles. That's who we integrate with. But this is how we integrate. So we've got our functional partners, and but what we need to do is go one step beyond, just talking about things, and we need to integrate the workflows, our resources, our strategies, and we are doing this with many of our functional areas, and we are expanding this beyond what we're doing. But what we really want to look at is those opportunities within strategic plans where we could really support each other for the greater good of the organization. And then, of course, identifying those metrics, we're all keeping metrics, we can identify those metrics of outcomes that truly support what we're looking for, and that is actionable solutions. And then integrated technology, you know, we've got our HR system, we've got our time system, we've got our KP Health Connect system, and we have the opportunity to integrate those systems so that we can truly measure both, again, the impact of disability absence and then the impact and outcomes of what integrated disability management does, and in this whole, I guess, concept, this paradigm of total workforce health. And in terms of the opportunity for communication education, again, you heard this before as well. Educate, 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 communicate, clear communication. Well, I'm not just here to communicate about IDM. Our IDM communication has to include messaging about EAP, and EAP communication has to include messaging about workforce wellness, and you know, and attendance communication needs to talk about those safety nets for people that are having attendance issues because they are having health problems. So it's really important that we cross-message what we're trying to educate and what we're trying to reinforce. And then, of course, we hope that total workforce health and IDM is a key priority in the development of KP policies. It already is, and we are not shy about offering to sit at the table to further influence and impact the development of new policies. So with that, I turn it back to Nicole. Thank you. That way.
I had to pry myself out of the Jimmy Fallon chair over there. It's very comfortable. Okay. So this is part of, taking a little bit more detail then in some of the programs that, in this case, are used to then support IDM. With EAP, these are some of the objectives that the EAP program at Kaiser Permanente focuses on. And a lot of this will look, obvious, and hopefully will look obvious or be more than familiar with it. And I think the difference or the nuance that we're trying to focus on is that in assessing whether your EAP program is successful, you want to look at some of the outcomes of your disability program and vice versa. Here are some of the tactics that our EAP program uses. There's an EAP IDM toolkit, which is essentially a set of information and resources that are provided to managers when they have employees that go out on disability. Injured worker orientation, again, reminding the injured worker or whomever is going out, whether it's short or long term, or regardless of the reason or cause, that there is this additional, benefit for them and for their family. I all know when, and we've heard it even this morning in the JCPenney presentation, is that it's really long-term absence can be very, very disruptive to family and to finances. EAP, bringing EAP in can help to mitigate a lot of the outcome or a lot of the fallout from that. And part of the results of this was just launched last year is that there was a really nice increase in referrals, cross-referrals between the Kaiser IDM program and the EAP. I'm going to go through these relatively quickly. There's just quite a few. This is generally about Kaiser's healthy workforce programs. And again, thinking in terms of what, how we would measure success in any of these programs by looking at the disability or maybe even OC health. So online healthy lifestyle programs, some of you are going to hopefully have been familiar with this or have seen it before. There's some more of the WELS resources. And a lot of people that you'll find, and again, back to integration and how you define that, a lot of the champion groups you'll find cross-pollinated with people from EAP, from IDM, from OC Health, from wellness. So it's not just wellness people on wellness committees or OC Health people on OC Health committees. They're cross-pollinated into those groups. Really quickly about how we then envision using the Kaiser clinicians in this process is thinking in terms of work as therapeutic or on the path of making things better, of getting better, of healing. And it's a very different way from just treating an injury or treating someone who's sick. And I think Marlene alluded to this a little bit earlier, that having our physicians focusing on safe, modified transitional work duty is a lot different than just out and in for work status. This is a screenshot of our online resources we provide for KP clinicians. Integrated Disability Management at Kaiser has an entire site dedicated to providing workflow, backgrounding information, guidelines for absences, which I'll show you in a second. And something that we're really proud of is a tool that we call ActivityRx or ARX. And it is a tool that KP clinicians use that overlays our Health Connect electronic medical record system. And what it does is it provides easy access for the clinician, real time, to read guidelines around modifications, around absences, sorry, I'm drawing a blank here. Absences for different diagnoses, different comorbid or premorbid conditions. And so they have that readily available to them right in the electronic medical record system. And here's an example of some of the integrated measures that we're working towards. So again, trying to identify the success of any one of these programs by measuring them essentially against the outcomes of the others. So tracking referrals between IDM and EAP, identifying risk factors and participation rates with wellness, and then types and frequency of services around return to work. And we're looking for correlates really around what are identifiable targets, again in a metric sense, that any one of these programs could be used to target. So if it's a certain kind of disease or absenteeism, that it's not just something we're looking to target with IDM, it may be also pulling in EAP as part of the intervention, certainly wellness as part of the intervention on the prevention side. And here's a couple of examples around some of the overlap between workplace safety and then our leave management. That's you.
We're back to me?
Yes, you are. We are back to you.
Yes.
Thank you. Okay.
Okay. Sorry. So you've heard a lot, and I think I talked a little faster than I planned to, but that's okay. It means we'll have time for questions. But to get to the beginning of how we're going to wrap things up, making total workforce health and using IDM as your tool, your vehicle for making this successful in your company, the first thing you want to do, define your vision. Define what you're trying to accomplish. And we know it's about wellness, and we know it's about, or maybe you don't know, but hopefully you learned today that it's about keeping your employees healthy, keeping them safe, and hopefully keeping them at work every day. But what you really need to do to accomplish that is to build those strong relationships. Of course, I put IDM at the top of the list because that's where I step in, but working very closely with your occupational health resources, with the EAP resources that you have, your workforce wellness programs, workplace safety, work with your disability and workers' comp carriers by all means, and even go beyond that level of integration to other areas within your company or your organization that can help support your total workforce health and IDM efforts. You're going to want to identify challenges and gaps, and certainly using metrics so that you can identify those common metrics that your integrated functional areas, your integrated departments collect to help tell the story that you're trying to tell and help drive home the message of the importance of your total workforce health and IDM program. And integrate, integrate, integrate. And what else do you need to succeed? You need to make total workforce health not only an HR, but an operational priority as well. And that's been my mantra for the past, about a year or 2 years, is that IDM and total workforce health are an operational solution. When we reinvented ourselves, the one thing we didn't do was ask for more money. We never said, well, we need to increase our budgets to hire more people in the IDM world. No, we never asked for that. All we asked for was support, and we asked to make this a priority, and then we promised to deliver the solution. But you certainly want to have ongoing engagement with your stakeholders, with your leaders and stakeholders. It's critical that you have that. And in order to have that, you've got to have the data to demonstrate it. So you certainly want to make sure that your technology infrastructure has the capability of capturing these meaningful metrics, that perhaps your technology infrastructure is relational, cross-functional, and certainly accurate and reliable. And I say, why not insist on leadership accountability? I actually added that insist as a result of listening to all the presentations and the other employer groups that are having success. Well, I say insist on leadership accountability. Have this be part of line of sight goals. Have this be part of the operational goals for your leaders, because ultimately they're the ones that are going to win. Well, the employees, of course, too, but everybody wins, let's face it. So, final thoughts about IDM program optimization to support total workforce health. Total Workforce Health and IDM are both about preventing employee illness and disability, and this shared focus preserves employee productivity. If you include leveraging the programs of your key functional partners, at the end of the day, everyone will celebrate shared successes. Thank you very much. Any questions?
So in 2000, your labor management partnership mandated IDM.
Yes.
In hindsight, had you clearly quantified the problem or issue that was the solution for, or did you put the solution in place before you had the real chance with data to say, and here's what we're trying to solve, here's the problem we're trying to solve with IDM, particularly given the paucity of data from the state disability insurance program in California?
Yes, the solution was designed before the data, and maybe that's why it took as long as it did to get the leadership support. But I mean, I wasn't even working for Kaiser then, and I can play armchair quarterback and say, why didn't we start with the numbers? You know, they weren't so easy to get back then. We know that. And the important thing is to look forward, you know, looking to the future. We know what we have now, we know what we can use, and we're using it. Yes?
That was an admirably complete survey, but I did sense one empty chair at the table. And that is, to what extent does or should total workplace health inform hiring and retention decisions?
That's a good question. And what are your thoughts on that?
I think my first thought is I'm not sure how much of that you can actually do with ADA and that, and nor would you maybe want to do if you have as diverse a workforce as Kaiser does. I'm really kind of thinking or talking off the top of my head, but I think that would be a really tricky decision or set of decisions.
You know, I remember when the task force had its first meeting in 2011, and one of our regional HR VPs, as a matter of fact, said, is our IDM program going to take on pre-employment screening, pre-employment physicals, pre-employment health? And we decided that the IDM program wasn't going to take that on. But now that we're part of the total workforce health, I'm not saying that it's going to be something that we take on, but the way we do things at Kaiser Permanente, we really take the behavioral approach. You know, we encourage the healthy behaviors, we encourage the healthy activities, and yes, of course, you know, we have our total workforce health incentive program. We want you to get health status assessments, and you know, definitely we encourage all of that. But we're really driving more toward the behaviors. So, you know, I guess we take our chances when we hire somebody, and then we work to Kaiserize them so that, you know, we feed them the Kool-Aid. It worked on me. And we hope that we inspire healthy lifestyles, healthy choices, and we certainly provide them with so many tools to make those healthy choices. Best I can offer.
So I've got a question on two things. One, how do you, and who's responsible for tracking those transitional days? And do you have a single system that you're integrating, putting it all together? And then two, do you put parameters around the length of the transitional duty?
Yes. So the answer to the first question, and it's a great question because it's one, that's one of the reasons why we're so motivated to find our solutions in an electronic way, whether it's a database or whether it's utilizing Oh, gee, our time system, what a novel idea. In Southern California, they actually have a time code for transitional work days. So when we want to know how many days did you recover, it's really easy. They get it out of the time system. Northern California has their electronic database, and they do capture it. And in our other regions, they're getting it in various different ways, and that's why I think we're probably under-reporting. I think more is actually going on. Managers just saying, sure, come on back, and let me put in a requisition to get you a sit-stand desk, or let's get you a new chair or something, so that, you know, until you're actually fully back to full speed. I don't think we're doing the best job of measuring it, but I was just invited to participate in a committee by our HR technology department that is doing exactly that and looking at a new time system and looking at what is the best way to measure everything that needs to be measured. And at that table, integrated disability management, so I know I cast my first vote for tracking those transitional work days, but then we also have attendance at the table in HR operations and workplace safety. So I think we're going to start seeing some positive changes. Our transitional work program is designed for a 90-day length of time, and under certain circumstances, it can be extended, but it's not meant to be a job replacement program. It's really meant to be that transition back to full-time work. And it might be full-time work with a permanent modification, and that's great, but eventually the transition needs to be to full-time work. Yes?
Let me make a comment about your answer to the hiring and firing. I think you're making a tremendous difference in the hiring and firing just by being what you're doing. Because if you let the employees know that you really care about them and you're tracking all these things, that'll be a great thing for retention. And if you advertise it right, it's a great thing for recruitment. So I think what you're doing is really right on what this whole field is about. That's a business incentive, that's a business model, it's a business data. That's what you're about, is hiring and firing, hiring and retaining, sorry. And really, you're on the right track.
Well, thank you. I could have said it better myself, other than to mention that, the IDM program sort of falls under I don't know, financial performance, or I'm thinking about my goals and objectives, and financial performance and our whole affordability, our drive to sustain our affordability, but it really has a lot to do with being a best place to work. And supporting employee satisfaction and making it truly a best place to work has a lot to do with why we do what we do. So thank you so much for that comment. I didn't even pay him to say it. I don't even know who he is. Anything else? Well, I think we've given you the gift of time. But thank you so much for listening, and enjoy the rest of the conference.